This is an example of a patient who presented with low back pain and leg pain for the last 12 months. 80% of his pain was in the leg and 20% in the back. There were two components to the leg pain. One was a dull cramping pain in bilateral posterior thighs, and the other was a sharp pain radiating to the right foot. He had tried medicines, physiotherapy and injection, but was not relieved. It was affecting his day-to-day activities. This is the radiograph showing L4-L5 spondylolisthesis, which means slipping forward of one vertebra over the other, leading to spinal stenosis. This is an MRI scan showing the slip as well as the reduction in the spinal canal at the involved level. The figure on the right shows the normal spinal canal which is available. There are three basic options for this patient. One is to do nothing or to follow the natural history of the disease. However, we know that chronic, long-standing compression could lead to nerve damage and could lead to permanent numbness and weakness of the foot, and is therefore not a good option. The second is to continue with physiotherapy and medicine. However, it is not permanent cure and uh, does not relieve the problem. The third option is to undergo surgery, and there are basically four options, surgical options available. The first is decompression alone, which means to decompress the nerve. However, because there is a dynamic component of the compression, and every time the patient moves forwards or backwards, there is compression on the nerve because of the loose vertebra. Therefore, decompression alone doesn't always give good symptom relief. This is a study from the New England Journal of Medicine confirming that laminectomy plus fusion results in a meaningful improvement in overall quality of life than laminectomy alone. The second surgical option is to do decompression with posterolateral fusion, which means without adding an interbody cage. However, because an interbody cage is not added, the height cannot be restored and the rate of fusion is also less. Systematic review has shown that an interbody fusion can improve the clinical satisfaction as well as the fusion rate as compared to posterolateral fusion alone. The next two options involve an interbody fusion. One is an open technique and the other is a minimally invasive technique. The figure on the left shows how the slip leads to a compression of the nerve and a pinched nerve, leading to numbness and pain in the leg. The figure on the right shows how the placement of an interbody cage can increase the height of the neural foramen, resulting in decompression of the nerve. A posterior decompression is also done along with the addition of the cage. The next figure also showing how the cage and pedicle screws are placed to achieve fusion. The other advantage of an interbody cage is that it restores the normal lordosis or curve of the lower back, which cannot be done in case of simple decompression and posterolateral fusion. A figure showing the comparison between an open TLIF and a keyhole or a MIS TLIF. The larger incision and disruption of the muscles is shown in the open TLIF. A clinical photograph showing how much of the wound is created in an open TLIF, whereas in an MIS TLIF, tubular retractors are used and the amount of tissue destruction is much less. The technique of MIS TLIF involves placement of tubular retractors through which the operation is done using a microscope. The figure shows the view through the microscope and how much of the bone is resected. Finally, the interbody cage is inserted through the tubular retractors. The X-ray showing the final figure of final X-rays of the patient, and he had improvement in his leg pain as well as his back pain. A meta-analysis has shown that a minimally invasive or a keyhole interbody fusion results in less blood loss, less pain, decreased chance of infection and shorter hospital stay. However, the procedure requires special training and a learning curve. It can be made safe using microscope, neuromonitoring as well as image intensifier.